Hi, my name is Kayla Wolf. This is the impact of bedside report on medication errors. The purpose of this project is to identify interventions that will decrease medication errors made in advanced heart failure patients on a cardiac unit by using the best evidence on the implementation of bedside report. A little description on the practice problem. That NEHI is preventing medication errors, a $21 billion opportunity. States each year in the U.S. serious preventable medication errors occur in 3.8 million inpatient admissions and 3.3 million outpatient visits. The Institute of Medicine, in its report to Error is Human, estimated 7,000 deaths each year are due to preventable medication errors. That NEHI also states that healthcare spends $21 billion annually on preventable medication errors. At my current practice environment at Strong Memorial Hospital, we have had 8 medication errors reported in the last 6 months on my unit alone. This is a huge problem because obviously there should be none reported. Medication errors can have a significant impact on the patient's safety and can result in patient harm and even death. Poor nurse-to-nurse communication is a big component in medication errors. One way nurses can improve nurse-to-nurse communication is during shift report at the bedside. Nursing bedside shift report involves oncoming nurses receiving a report on the patient from the offgoing nurse at the patient's bedside. Research on the implementation of bedside report has suggested that it can reduce patient falls and medication errors. In a study conducted by San, Jekyll, and Sherman in 2014, medication errors were measured 1 month pre-implementation of bedside report and for 1 month after 3 months of implementation, and found that there was a 50% reduction in medication errors after implementing bedside report. The clinical question being investigated is in advanced heart failure patients on a cardiac floor, how does the implementation of bedside report versus regular nurse-to-nurse handoff at the nurse's station impact medication errors? So my evidence search process, I use the following databases: Cinol, Cinol Plus, and Medline. Some keywords and search terms I used were bedside report, errors, bedside handoffs, and medication errors in patient safety. The results were limited to journals from between 2012 to 2017. Some terms yielded more articles than others. There were over 2,000 articles generated with the search terms. I reviewed 16 articles initially, and studies that were greater than level 3 were excluded. I reviewed the abstract of the articles, and I chose the six articles that are selected in my table of evidence. You can find that on the next page, as well as my search history. I also used the University at Buffalo's University Library website to get an idea on the evidence available on bedside reporting before I started the project, but I did not use any information or any articles from there. So as I said, the table of evidence and the search history table can be found on the next page. Data extraction. Based on the 6 articles selected, bedside reporting was found to have a positive impact on the overall safety of patients. In a study by San, Jekyll, and Sherman in 2014, after 3 months of implementing bedside report, they had a 50% reduction in medication errors and also a reduction in patient falls. A case study also found that bedside reporting led to decreased medical errors and patient falls. The nurses in each study were found to have an increased satisfaction with patient safety and nursing communication. The qualitative study conducted by Jeff et al. 2013 states, our study findings highlight how nurses positively viewed the change to bedside shift report in terms of improving patient safety and to a lesser extent enhancing their accountability. Bedside report allows nurses to see the whole picture before they assume care. Nurses are able to identify patient safety risks and act on those before harm occurs with bedside report. Maxon, Derby, Warbleski, and Foss 2012 found that bedside reporting provides nurses the opportunity to do a 2-nurse check of IV medications, which can reduce medication errors from occurring. This is actually a requirement on my unit. We have to do a 2-nurse rate dose verify at the beginning of each shift. The studies reviewed all concluded that bedside report increases patient safety, can reduce patient falls and medication errors, and can increase both nurse and patient satisfaction. These studies were implemented on a different variety of units with a different sample size and different patient populations. A limitation to these studies is that most of these studies use direct nursing interviews to evaluate these studies and the data, which could be biased because it's based on nurses' personal experiences. So further research could be beneficial. Practice recommendation. So the following recommendation is based on an analysis of best evidence to assess the impact of the implementation of bedside report on medication errors in hospitalized advanced heart failure patients on a cardiac floor. So I suggest that bedside report should be implemented at Strong Memorial Hospital on their cardiac unit as a pilot study. The pilot study will need the approval of the Institutional Review Board. The Institutional Review Board will be presented with the data from previous studies that concluded that bedside report decreases medication errors. The IRB will be presented with specific information about the pilot study and how data will be measured. After approval, the evidence-based practice team will provide staff an overview of this pilot study on the implementation of bedside report at a staff meeting on the cardiac unit at Strong Memorial Hospital. The patient population on this unit is advanced heart failure patients. Staff will be presented with information regarding other studies and on the impact of bedside report and how it has impacted medication errors. Staff will be given the opportunity to ask questions and share their thoughts and concerns. The study should not cost the organization anything. If this is successful, it will ultimately decrease the cost because medication errors should not be occurring. Access to data on medication errors reported will need to be available for the accuracy of the data collection. Staff will begin implementing bedside report 1 week after the staff meeting. The evidence-based practice team will provide nurses with a survey at the staff meeting prior to implementation that addresses their views on regular nurse-to-nurse handoff and how they feel bedside report will impact medication errors and the overall nursing satisfaction. The nurses will not be required to include any of their names. It will all be anonymous to protect their identity. A survey will be handed out at the end of the 6 months at another staff meeting to address their experiences with bedside report. Data on medication errors reported will be collected pre-implementation of bedside report and at 3 and 6 months of implementation of bedside report. The outcome of the pilot study is to decrease medication errors by 50% from pre-implementation to post-implementation. By the end of the study, we'll be able to measure if medication errors were decreased with the implementation of bedside reporting. If medication errors are decreased, this will be cost-effective for the healthcare organization and will help support that bedside report promotes patient safety. In order for practice change of implementing bedside report to be sustained, full participation from the team is needed. Sadul Rios et al. 2017 states, when healthcare professionals are not cooperating and communicating effectively, patient safety is at risk. Critical patient information such as change in clinical condition and abnormal laboratory tests can be missed in the handoff process. For bedside report to be successful in improving patient safety and reducing medication errors, nurses have to be willing to take their time giving handoffs so that no crucial information is missed. Bedside report should be used as a way for nurses to tell a story and paint the picture for the oncoming nurse. In some instances, when details may not be appropriate to share in front of the patient, or for instances, they have a roommate or family or friends are visiting, due to HIPAA, you can step outside the room and share those details at the door. During bedside report, nurses will be required to do a 2-nurse rate dose verify in the MAR if the patient is on any continuous IV drips to assure the IV pump is delivering the correct amount of medication. And bedside report will be required to occur at every shift change. For my references and my table of search history and table of evidence. You can find that on the next page. Thank you.